Take the entire population, screen everybody for diabetes. Don't leave anybody, take everybody. That's a big logistical challenge. The other way to look at it is take the population, take the high risk people and then screen them for diabetes. Those are the low hanging fruits. If you take high risk people and then screen them, then you may get more cases from the community, and that's what we did. And of course, women have another problem because women are, in our country, women are not given care on time. Women often are the last to take care in health activities. They are the last to get health care. They are last to get guideline modulated or mandated care. And they go through puberty, adulthood, menopause and old age. And this is of course a mobile diabetes clinic they take care. And if you see abdominal obesity in rural women, this is the paper we published, and we found that whether you look at men or women, there's a huge prevalence, 30 to 35% prevalence for obesity. And if you see this diagram, this picture, this is in the mobile diabetes clinic, and you'll see all the women are waiting till the men are first to get into the queue for the checkup. Our mobile clinic also has a TV where we run some diabetes videos to watch. And this diagram shows you, when you look at it carefully, the men are not doing all the hard work. They are in the fields or in the side of the fields, they are talking, but the women do the hard work in the field, they take care of children, and even to get health care, they are the last. Men actually go in quickly. And they are all men, and we men are always happy and good people. All of us are good people, but when it comes to making sure that women also get the same care, women also participate to the same extent in any activity. It could be healthcare, science, education, technology, engineering, medicine, whatever it is, and that's very important. And this is me with the mobile diabetes clinic team, and you can see all the men standing. So this is important. This is another child. A small child with type 1 diabetes from the mobile clinic, and this girl has no access to insulin. She gets insulin only once in a month. When her father brings insulin and she gets the insulin, she feels so happy. On the days when she does not get insulin, she has abdominal pain, maybe even subclinical ketosis. This is Dr. Vedavati Purandare. She is the head of our clinical care in the hospital, and she saw this patient and we helped out this child. So this is the reality of diabetes in India. The reality is not the diabetes that you see in urban practice where you do HbA1c, biotishometry, ABI, you do CT angiogram, you do fundus photography. All that is there, but there is no awareness and nothing in rural parts of India. And that experience, we tried to get more experience from it. So this was our model. So we studied more than 900 villages. Take a small village, our ASHA worker or accredited field workers, the community health workers, will go to the small village and enlist see all the people in the small village. She will do a questionnaire, which is not the diabetes risk questionnaire that is there, but modified. We added things like, do you have eye problem? Do you have foot problem? Do you get recurrent infections? So we added all that to our scores, and then we called the patient. And then when the mobile clinic visits the spoke, the ASHA worker will bring the patient. So from the hub, our mobile clinic will go to the spoke, and in the spoke village, the ASHA worker will round up all the patients. So we did what is called high risk screening, and this is, of course, now we have done 10 times that number. We found that the pickup rate, that 1 in 5 if you screen will have diabetes. So instead of screening everybody, it is better to do high risk screening. This is the design of our mobile clinic, and we can share it with you anytime. There is a registration, there is a examination, and this is a registration. The patient comes like this, registration is done, patient lies down here, examination is done, and then there is a fundus camera, and there are few seats for patient to wait, and after they finish, they exit through this mobile clinic. So this is how it is: the registration, the examination, the fundus evaluation, the glucometer testing. For sometimes we even had point of care HbA1c testing for a short project. And our project actually was cited by the ICMR in their white paper, that they said that instead of asking the patient to go from their house to the PHC or primary health center or hospital or lab for screening. We should innovate and get ways where you can get a mobile diabetes clinic or anything to go to their patient's house and then do the testing and then give them awareness in diseases, chronic diseases. That is more important. And to do that, we have to harness what is called community health workers or accredited social health activists. So we looked at our project from the eye of obesity, and we looked at 29,324 initial patients we studied. We found that almost 26% are obese. So we have an impression that in rural India, people are all working in the fields. They are very active. They eat little food and they are very muscular and healthy. No, that's not true. In fact, when I went to one of the villages, I met a potato farmer. I found that the potato farmer was making potatoes, but he had a packet of Lay's chips in his house. So the same potato he is selling to the company which is converting them, processing them into the unhealthy Lay's chips, and then he is eating that. So if you see, in the villages also, you will find nothing to do with Lay's chips. I'm just explaining that you will find fast food, and because of mechanization of farming, people don't have to really do hard work in the farms. Maybe in the cities we may have to do hard work, but in the farm we don't have to do hard work anymore. It's all mechanized, and because of that, sedentary life is very common. We also found that if you take the non-diabetic people and if you look at new onset hypertension and diabetes, we found that as the BMI goes up, the prevalence of new onset hypertension and new onset diabetes goes up. So almost 11.4% new onset diabetes and 20% new onset hypertension, and that is in the study of 29,324 patients. So obesity, this is the first single center large scale study of obesity in India, and we showed that obesity is present in rural India. It's easy to say that there are a lot of challenges in diabetes. People have challenges, okay, what to do? That's life. Second, you have some experience of screening. Yeah, we screened, we found there is 10% diabetes, 20% diabetes. Okay, what are we doing about it? What should we do about it? Supposing we see a channel on TV and we see some program going on it. Oh my God, there is so much sorrow in the world. What to do? Let's just change the channel. No, we have to actually act, and we have to think how we can actually design a way forward. I'm not saying we succeeded, but we tried to find what could be a way to make sure that diabetes is better taken care of in rural India. And before this, I had published this paper in the Annals of Internal Medicine 2016, and this was a CAR study, and we did this study in urban India when I was at the Amrita Institute, and here we looked at care coordinators. Care coordinators will help doctors give guideline mandated therapy. They will make sure that patient comes at the correct time, patient is educated, doctor is also given the guidelines, and that helps in guideline mandated therapy, and that improves glucose control, quality of life, etc. And this study was conducted in many parts of India and also outside India, and the paper was published, and that gave me confidence. If this can be done in urban India, why can't this be done in rural India? And therefore, I hope that this project may have implications for a rural project, and that our rural project may show a similar effect. So therefore, we started this project called Diabetes with Dignity, which was our third mobile clinic program, and we thought of intervening, and then we called it a pilot model for enhanced diabetes care in rural community. There were many partners. There was the Public Health Foundation of India. There was a whole Diabetes with Dignity team. Sanofi partnered. The Maharashtra Arogya Bhavan partnered. In fact, I went many times from Pune to Bombay to the government Arogya Bhavan with our team to make presentations and discuss with them. And the central government health services, the Health and Family Welfare Ministry also participated in this. So basically what we did is this. We took our team to the villages and we trained the rural health workers. Now these rural health workers will go to the patients' houses every month. First month they will talk about diet, exercise, then every time they'll do glucometer testing, they'll do BP, second month they'll talk about First month maybe diet, second month exercise, third month complications, so on and so forth. And at 6 months, what's going to happen to these patients? And we needed a control group also. So this is how we looked at it. We took a intervention arm, which is a PHC with a cluster of villages, and a control arm, which is also a PHC with a cluster of villages. These two were matched to be similar in terms of socio-economic status, a number of people, the type of people, etc., etc. And then we, in the intervention arm, the ASHA workers would make monthly visits to the patient's house. Remember, no doctor, only ASHA worker, community health worker going to the patient's house, but trained by us. And then at the end of 6 months, we would see how they are.